Hello, everyone. I'm Adam Leventhal, Director of the Institute for Addiction Science and a Professor of Population and Public Health Sciences here at USC. And really excited to announce our great speaker, the special speaker that we have for this co-sponsored event between the Institute for Addiction Science and the Department of Population and Public Health Sciences. So hopefully folks online can hear me for this hybrid event, but it's great to see so many people who've zoomed in, and of course to see people live and in the flesh, to see Dr. Dustin Duncan. So a little bit of background, really excited to have the privilege to introduce Dr. Duncan. I call him Dustin, so. All right, so Dustin, he's an associate professor of epidemiology and very soon to be full professor at the Columbia University Mailman School of Public Health. He's also the inaugural associate dean for health equity research. Also co-directs the Spatial and Social Epidemiology unit, and additionally directs the Columbia Spatial Epidemiology Lab. Okay, so he directs a lot of things, right? And so we're really excited. He really is one of the preeminent scientists in the field of social epidemiology and spatial epidemiology, both in terms of substantive, his contributions, also his methodological contributions to this field, and particularly his work focusing on neighborhood influences, urban health, sexual and gender minoritized populations. He's really just well known. And he doesn't focus just on a single outcome. He focuses on many different outcomes: mental health, sleep, substance use, HIV risk, and many others. So we're really excited. Just a little bit of background about Dr. Duncan, if you're curious to see how he got here. So Dustin, he went to Morehouse College in Atlanta, where he got his bachelor's in psychology. And then he moved on to Harvard University, where he got his master's at the Chan School of Public Health, specializing in social and behavioral sciences, and then went on to get his. They're not called PhDs at Harvard, as some of you know. They're called Doctors of Science and Social and Behavioral Sciences. He stayed on there for a postdoc at Harvard School of Public Health, and then he became faculty at NYU in the Department of Population Health in the School of Medicine there, and was there for several years. And then he got recruited to go to the other side of Manhattan, and has been flourishing ever since, and for the past few years at Columbia. And as I mentioned, they're even building this inaugural associate dean for health equity position, which is a really, really innovative. And Dustin is the perfect person to do this, to really think about synergy across his entire school and bringing folks together in the area of health equity research, and probably across the entire university. Columbia is a big place. So the guy has more than 200 publications, more than $20 million in external funds from various agencies, including the NIH. He's actually PI or multiple PI on 4, I think, R01s right now. So I don't know how he finds the time to do all this, but he does. So we're really excited to have Dr. Dustin Duncan. Come on up.
So Adam's introduction was quite generous, so I hope I live up to whatever you may perceive or think. But I also just want to note, I had terrible coffee in my hotel this morning, so this is my second cup. I need 2 to be quite on, so yeah. So today I'm going to talk about nothing for us without us, the role or really necessity of intersectionality and positionality, not or, in health equity research. So first, I'm going to talk about this introduction to myself. I think who we are actually shapes everything. And I'm going to say a couple examples from my personal life that have influenced what I study, how I study it. And I'll talk about some, I wouldn't say they're rigorous experiments, but some experiments that I've kind of done with colleagues to see how their perspectives could potentially influence their work as well. I'll spend a lot of time talking about health equity, which I think we all think about when you inherently have some type of social justice lens. Then I'm going to talk a lot about intersectionality, positionality. I recognize that some of you, these concepts may be new, or you've heard some of them in depth, some of them. So as I provide this kind of overall view, I'll also provide some influences or discussions on how they relate to my work in particular. And then I'll end with some recommendations. Some of these recommendations are things that I'm currently writing about right now, so they're not actually published yet. So I appreciate the dialogue to make these products better. And then finally, I'll talk about this project that we are hoping to get launched in Nairobi, Kenya, that's focused on Black sexual minority men. And my colleagues and I are really using this as an exemplar for applying some of the principles and policies that we're suggesting that others do in the field. I first want to provide this dedication. So I dedicated my book, it comes out in, I can't remember if it's October or November, called The Social Epidemiology of the COVID-19 Pandemic, to my uncle, Dr. D.K. Duncan. The reason why I dedicated to him because he truly was a healthcare warrior. I can say many things about him because I knew him, he's my uncle, but I'll just say a couple. One, he trained as a dental surgeon in McGill in Canada. And when he came back to Jamaica, he was known for giving free dental care to people who couldn't afford it, quite literally. He realized that there was inequities in the Jamaican society, and we can talk about that, although it's not salient to this. And so what he did is he realized that in his role as a healthcare provider, he couldn't make the large-scale changes that he felt were needed or necessary to actually change the societal structures and policies. So what he decided to do is to become a politician. And I was going to read the tribute that I wrote in my book to him, but instead I'll just narrate a couple of things that he did. So I'll provide it in a little bit US terms. He was kind of the equivalent to a governor, equivalent to senators, and then he moved up to be ultimately a governor. And some of my cousins have kind of followed in his footsteps in different generations or different ways. It's ironic that he died from COVID for so many reasons. So my cousin, and my first cousin, who's one of my closest friends, is a physician. And essentially, she and others have highlighted that he actually died because he had one kidney. And the reason why he does is because he was poisoned. He was poisoned by who knows, but we assume by a political opposition. So quite literally, he died for the causes that he cared about. So I think a lot of times in talks, I'm pretty passionate about the work that I do. And so I think sometimes some of the messages could be lost. So I want to make sure that I say it at the outset, but also that I repeat it. One, both positionality and intersectionality matter. They're necessary. And they're needed, I think, for all research, but ironically, and especially for health equity research. As importantly, what I'll try to do is provide some feedback loops as I see them, kind of historically in some of the historical scholars or preeminent early scholars, rather, is a way to say that, who've discussed these topics, but also in some of the thinking that I've been doing as well. So as an epidemiologist, it's always cool and super easy to say, you know, all these health disparities exist and talk about the range of disparities and a range of contexts and a range of things, which I will. But I think that we all have different perspectives on why this matters to us. So I'm going to highlight it from different perspectives. And I'm going to start with the economic perspective that I get the sense that people care about first. So this is a recent paper that was published in JAMA Network Open by Tom Leveist, who's the Dean of Tulane University School of Public Health. And what we do a lot of times in our data sets is we ask questions in different ways. So we ask questions with different data sets to partly triangulate to make sure that we get the right answer, right? So what they did is they wanted to quantify the economic burden of health equity or health inequalities due to race, ethnicity, and they wanted to qualify the health inequities due to socioeconomic disadvantage. So there are two different data sets, so they found two different numbers, and I intentionally decided to highlight the lower end of those numbers. So when it comes to race ethnicity, it found that the economic burden of these disparities was $421 billion. And when it comes to SES, they showed that the economic burden of SES disparities was $940 billion. What I'm especially interested in is the intersectional analysis that highlights the economic burden for people who are both racial and racial minorities and who are socioeconomically disadvantaged. And I imagine that intersectional economic analysis would highlight there's even more billions, of dollars. So I'm going to provide a quick introduction to my intersectional positions. When I first came to Columbia, what I did was I would start my talks off by saying who I am as a way to introduce kind of my disciplinary perspective to my colleagues. Like, Dr. Leventhal, you're a preeminent psychologist, and we've talked about some new book things, and you've taught me things about psychology, et cetera. And I know that because I know you, but if you didn't know me, you wouldn't necessarily know how my disciplinary training may influence what I think about, how I think about, et cetera. So I kind of gave this kind of boilerplate slide, which I updated a little bit about, I have papers, so I can write a paper. I've written a grant, therefore I have skills in writing grants. I have expertise in social epidemiology, which means I think of these type of issues or models. I think about social production of disease. I think about preeminent scholars like Nancy Krieger and Achiro Kawachi, et cetera. But what I didn't do was actually talk about who I was and how who I am actually influenced my science. So I, like many colleagues, have started to develop positionality statements for myself. And I'll read parts of it here. I must admit, this is quite an evolving or living document / presentation. So with that in mind, I'll read the following. My position, and this is an excerpt from it. I'm a Black cisgender gay man. My Blackness and queerness are central parts of my identity, as in the pride I feel when I express my Caribbean heritage. When people see me though, I understand the first thing they see me is as a Black man. I'm American, born and raised and living in the Northeast United States. However, my Caribbean roots are salient aspects of my identity and shape my day-to-day realities. In fact, I'm not in New York now, but where I live across the street from a Jamaican restaurant. And not every day, but I would say at least once a week, I actually eat my Caribbean cultural cuisine. My DNA results show that I'm originally from West Africa, with 30% being Nigerian. Perhaps this is why I'm drawn to sub-Saharan Africa, including working in the Eastern African region. So let's think about this as variables now. As scientists, we break these things down as variables. So some of the identities I mentioned were Caribbean, okay? I mentioned a sexual orientation, gay. I mentioned things about race, Black. I talked about gender, cisgender. We could think about these as diasporic conditions, I'm calling them, as variables, but then we think about how we operationalize them. We can ask things about your ethnicity. What's your ethnicity? Where were you born, et cetera. So how many people think that my perspective or my orientation will influence the kind of questions that I have or the way I formulate my questions? Just generally put your hands up. I'm just curious. Okay. Well, I can say that it does. And I like to walk around, so I'm just gonna walk around a little bit. So this is a slide, and when I was preparing the talk, I asked two colleagues in the field, and I'll identify one, which is Orlando Harris, who's a associate professor, at UCSF. And I asked him the following. I said, okay, I have this question about food and culture, and I know that he has a K award, and we're planning some work in the Eastern Caribbean and maybe Jamaica as well, to study Black sexual men. And I said, here's this question. And I said, could you help me think through this question? And really, I asked my RA to email him, and he gave me a thoughtful response. And in the response, I only took this one food, which is called festival. I'll dig into what that means in a second. And he said he added this for fried grapes. Who is Orlando? Orlando's a gay-identified Black man who is Caribbean identified. He was born in the Caribbean and raised here. So he knew that this food festival in some other Caribbean places is called bake. There are many nuances to these things.
You can.
We're looking for like a mic so you can walk around.
Walk around away from that.
Okay, there you go. Yeah.
You can. They'll hear you on mine better.
Okay,
Yeah.
sorry about that. And I have another colleague in the field who, of course, I won't identify, but I just said, via my RA, I said, hey, there's this question, and could you just give us some feedback on it? And the actual response was, or the reason why I did it wasn't to create experiment, although I did, but the reason why I did is I wanted to get a sense on how to improve the question for the talk. I was like, I want you guys to get the best question possible. But this colleague who didn't represent the population basically had nothing to say about the culture. They gave really good feedback about the thinking through identity in terms of how gay men identify or sexual minority men identify in that particular context, given the person's work. But they almost completely neglected this aspect. So a few weeks ago, I was in St. Kitts for a wedding, a family wedding, and I was next to one of my cousins who just became a partner in a law firm. So we were just kind of celebrating her in a way as well. And I asked her, I said, what is this? In Jamaica, where my dad is from and where I culturally identify the most, we call it festival. Where I was, it looked more like this, which is called Johnny Cakes in the Virgin Islands. Where my mom is from in Guyana, it's called bake. So Orlando knew that across the Caribbean islands, people call it different things, but he understood that one kind of general term is sometimes referred to as bake. You may think that this perhaps silly but real example is stupid or not salient, but imagine the misclassification that we would get here. One, but then secondly, remember that across Caribbean Black men, we don't tend to even disaggregate. So if you think about that, we would completely miss someone's diet, perhaps. And therefore, when we look at the association between diet and anything, cardiometabolic, mental health, et cetera, we would completely miss association because we didn't ground or get that perspective correct. One of my fellows has a paper in review. We've been doing a lot of work looking at neighborhood police violence and the health and well-being of marginalized populations, including Black minority men. And we have this data set called N2. It's in New York, in Chicago and 4 cities in the Deep South. And we just simply asked this question to participants about being under and over policed. And this is not, I think, the most riveting, but one thing I thought was fascinating is that in our analysis, we do see site or geographic differences that Black sexual minority men say. So for example, here, when we look at the use of excessive police force, the perception of that use or that variable, the prevalence rate has varied by geographic location. Maybe there's something geographically going on or the perceptions or something. But of course, we asked these participants the near identical question or the identical question. So I'll talk about health equity now, but I'll just first say that health equity research as a field, I think, is currently being defined. And so I actually used Yale's Office for Health Equity Research's definition, which says that it interrogates the dynamic, cumulative, and interrelated structures of power, environmental conditions, and economic systems that produce inequities in health between different populations. Health equity research also identifies, promotes, and leverages unique community-informed protective factors that are traditionally undervalued and understudied. So this definition, from my perspective, really stems or really builds on this kind of overall health equity framework. And it really necessitates both understanding personal agency, so the individual, but also understanding their context. It explicitly talks about access to resources and opportunities needed to achieve the best possible physical, emotional, and social well-being. Explicitly acknowledges that the distribution of resources in a system of interpersonal and institutional oppression, and that the distribution of resources will perhaps mirror the distribution of health that we see across societies. I personally view it as an intersectional framework that addresses systemic change. When we think about certain aspects of health equity, these kind of policy or larger structural factors are already starting to be appreciated. So this is a framework from the National Institute for Minority Health and Health Disparities. It's a particular framework that focuses on sex, transgender, minority health inequalities. And I just want to highlight that they explicitly recognize that the individual is important, but they have this kind of multi-level framework that highlights that, yes, the individual is important in terms of their health and health behavior and the disparities that groups may experience, but there's a context to that. There are communities and policies that influence someone's health. I've written about this, and I wanted to just highlight one colleague in the field, Medina Agner from Brown, where she's actually developing databases of policies to look at how policies influence health in different groups, including sex, transgender, minority groups. So just briefly, social determinants of health equity are broad, and I'll highlight a couple aspects in this talk: race, ethnicity, nativity, socioeconomic status, and sexual and gender minority with a focus on sexual orientation. Just briefly, there are stark disparities in HIV across all of these social determinants. There are stark disparities in mental health across the determinants. My group has a new focus on mental health, given the mental health burdens that we experience as a society, and given the positive work that's done on the marginalized population that I study. There are health inequalities across these factors in substance use, as well as sleep. I'll just provide a couple snippets. These are data that one of my RAs and I summarized, which is just one example. We chose studies that are large sample sizes, studies that were robust, and studies that I felt had the strongest study design. And so while I decided to select one study, it generally mirrors the nature of the field. And if these topics are of interest, we summarized them in a book that Achiro Kawachi and I, as well as Susan Redline, wrote called The Social Epidemiology of Sleep. So here we see that there are stark racial disparities. We see especially disparities when it comes to short sleep duration by nativity, by race, nativity, and SES. When it comes to race ethnicity, we see that Black Americans are significantly, and more specifically, almost 4 times more likely to report very short sleep duration. And we can talk about sleep for a long time, but just sleep is important, both duration, quality, and other aspects about the sleep environment. This is a study that looks at nativity. Again, this is just one example of a study, but it's a study that represents the overall literature. We see here that people who were born in Spanish-speaking countries in this particular data set reported very short sleep duration. And finally, this is a slide that looks at SES disparities in sleep. And we see that there are large SES disparities in sleep. In particular, we see that every group that has a lower income of less than $75,000 per year report being more likely to have very short sleep duration. And for me as an epidemiologist, what's always kind of cool and what's interesting is to see this kind of dose response. So people who are at the lowest end of the socioeconomic strata have the increased risk for very short sleep duration. And finally, sexual orientation. We see that SGM status was significantly associated with each type of poor sleep in every subgroup. And again, this is national, good data. And here we have national data from the National Health Interview Survey. I just want to provide a little bit of context to LGBT health, because that's what our group mainly focuses on. I think it's interesting that this is an older study, but between 1989 and 2011, only 1% of studies focus on LGBT health. Well, we also see here, and I just recently have been working on this through a course I just taught, is that there are also disparities in the populations who are studied. So we see that of these 1% of studies, 86% of studies focuses on cisgender sexual minority men, 13% focus on sexual minority women, and 7% focus on transgender people. As note, I think that these numbers have updated, but I think it does speak to the production of the science that we have and the existing disparities we see in the literature. What I think is interesting too is that only in 2019 did NIH formally designate sexual and gender minorities as a health disparity population. So perhaps we saw less of this work because there was less of a identification of this population needing to be studied. So people didn't study that. And I won't dig into these disparities largely, but there are sexual and gender minority disparities in healthcare access, depression and anxiety, alcohol and drug use. So for example, here we see that all groups report being more likely to binge drink, use marijuana, and as well as other drugs. And these are data from the National Epidemiology Survey on alcohol and related conditions. And we also see there are disparities in HIV and other STIs. What we often don't talk about as much as the kind of the stratified work. So yes, we see that these disparities when we look at one condition. In this case, we talked about sexual minority status. But we didn't talk about within sexual minorities, there are subsets of people. So while it's accurate that and correct that there are HIV disparities that sexual minority men experience, we know that disparity isn't equitable. For example, we know here that 50% of Black sexual minority men will acquire HIV in their lifetimes, as compared to 1 in 6 sexual minority men overall. These are just some further data to demonstrate that, including that although Black sexual minority men sheer numbers are smaller, they have the highest actual cases of HIV. In line with many of the theories that we talk about, so one theory I'm thinking about is Bruce Link's fundamental causes. We highlight that when there's a new intervention, we anticipate that actually who would benefit most would have the better health, and who would be less, who's most marginalized in society will be less likely to uptake that intervention. So we see that here with the advent of PrEP, which I think is a powerful biomedical intervention for HIV prevention. We don't see actually disparities getting smaller. We actually see disparities getting worse or widening. And this is totally in line with Bruce Link's theory as well as other social epidemiology theories. And put another way, we see that white sexual minority men are more likely to use PrEP and to meet the CDC recommendations of 50% of the population having PrEP coverage, where unfortunately Black sexual minority men fall short. And unfortunately, the story isn't isolated to one aspect of a continuum or one health condition, which is what I'm trying to demonstrate, but it's also across the HIV continuum of care. So I just want to first highlight that, yes, these disparities exist, okay, but now there's a context to them. So I'm going to talk about social and structural factors that relate to sexual minority health disparities. And I first want to highlight that the context that prior to 1962, all states had laws criminalizing consensual same-sex behavior as felonies punishable by law, but there were differences in time periods of when these laws were struck down. In 1973, the American Psychiatric Association removed the diagnosis of homosexuality from the second edition of its DSM, but we also know that there are states that have, there are differences in when states banned conversion therapy. We also know that there's a context to employment, that not all states have equal discrimination, employment discrimination policies based on sexual orientation, gender identity. And as you see here, unfortunately, several states, especially in what's known as the Deep South, have no employment discrimination laws. We also know that there are differences in housing. So some states have laws that protect against housing discrimination, where other states don't. And we see here the same pattern. So if you look at the general consensus on what the social climate is across states, many of the same states that have adopted one policy kind of synergistically or not surprisingly adopt a related discriminatory policy. And finally, there are differences in hate crimes, including different laws that allow or facilitate hate crimes. And finally, there are differences in bullying. We know that certain states have not passed enumerated anti-bullying laws where other states have. Again, many states in the Deep South haven't passed anti-bullying laws. And so this is an older paper that I view as seminal by a colleague in the field, Mark Hatzenbuehler, but I think it's really important because it highlights that state level policies influence health. And there's so many papers that I could have drawn on, so many study designs, but I think this is a really important one. And so, so in this study, Hatzenbuehler and his colleagues considered 2 state level policies targeting sexual and gender minorities. One, the absence of hate crimes protecting LGBT individuals, and then no protections against employment discrimination based on sexual orientation. What did they find? I'll just share one finding for dysthymia, which is a mood disorder, and I'm learning about mental health. That they found that SGM respondents who were living in states with protective policies were no more likely to have dysthymia than heterosexual individuals, as opposed to, or in contrast, LGBT respondents living in states with no protective policies were 2.5 times more likely to have dysthymia compared to heterosexual individuals. So with this context, let's think about intersectionality and positionality, starting with intersectionality. Intersectionality suggests that the various structural identities, gender, race, class, ability, et cetera, interact to produce expressions of privilege and power or impression. And it really highlights that, so the core tenets are privilege and power, or some of the core tenets. And it says that this privilege and power really shapes the intersectional positions that influence, for example, Black sex minority men's experiences and therefore their health outcomes and health behaviors. I think a lot of times in our science, we present these concepts as new, and I'm certainly not a historian, but of course I read the literature deeply. And so these concepts are far from new. There's a strong historical perspective to intersectional work. So early on in 1851, freed slave Sojourner Truth wrote a speech, I Am a Woman, who discussed the intersections of race and gender. But in 1991, Kimberly Crenshaw coined the term, so she's known for coining the term. And if you haven't read it, I'm just going to read a snippet of Sojourner Truth's speech because I think it's quite powerful. So here we go. That man over there says that women need to be helped into carriages and lifted over ditches to have the best place everywhere. Nobody ever helped me into carriages or over mud puddles or gives me any best place. And I ain't a woman. Look at me, look at my arm. I've plowed and I've planted and I've gathered into barns and no man could heed me. And I ain't a woman. I could work as much and eat as much as a man when I could get it and bear the lash as well. And of course, she's talking with the lash of her slave master. And I ain't a woman. I have borne 13 children and I've seen most all sold into slavery. And when I cried out a mother's grief, none but Jesus heard me. And I ain't a woman. So Kimberly Crenshaw coined the term in 1991 again, and it really drew on Black feminist writing as well as a critical race theory. There are many other scholars and colleagues in the field who have been prominent in this space. One is Patricia Hill Collins, of course, her book, Seminal, Intersectionality. And another one is Lisa Bowleg from GW, who recently with Greta Bauer has this Intersectionality Training Institute, if you are interested in the topic. I'll just provide some examples of intersectionality from participants themselves. So this is a quote from one of Lisa's papers that I really like from a Black sex minority man who is 37-year-old, and he says the following. Well, it's hard for me to separate my identities. When I'm thinking of me, I'm thinking of all of them as me. Like once you blended the cake, you can't take back parts to the main ingredients. I'm a gay man. Also, there's something to say about aspects of being a Black man. So in intersectionality, again, there are many identities that we could look at: race, ethnicity, gender, sexual orientation, et cetera. A lot of my work, I'm trying to incorporate a multi-level thinking into intersectional work because most of the work from my perspective is really focused just on the individual level. That being said, there's several ways that we could think about an intersectional analysis. One, which is our group squarely does, is we focus on specific populations that are marginalized. And early on in my career, I had some deep discussions with Nancy Krieger as an example, who we talked about the different questions that you get from within and between group analysis, which helped me think through this. We can examine simple interaction terms, effect modification, although you have to remember that you have to center privilege and power in the analysis. So it's great that you can do analysis, but it has to be centered in this framework. Some type of latent class analysis, and a colleague of mine in the field, who I think is doing some phenomenal work, John Jackson from Hopkins, is doing some decomposition methods to highlight and understand intersectionality. I'll provide one example from one bucket of this work, which is a paper that I wrote several years ago, where I just simply wanted to look at whether stress related to sexual risk behaviors among Black sex minority men. Seems like a really simple, expected association. But then in our group, we started to talk about, well, Black men experience certain things. One thing that Black men experience is incarceration. I'm not an expert on incarceration, nor have I been incarcerated myself. And I don't know necessarily all of the things that people who are incarcerated experience, but I started to talk about it with our group. And we started to understand that, well, people are incarcerated, you lose your voting rights in some states. When you're incarcerated, you actually can't do other things in society. So we said, well, this is a marginalized group. And for those who are incarcerated, perhaps because of their extra marginalization that they may experience, given that they would have less privilege and power, perhaps the effects will be exacerbated in those groups. So what did we find? Okay, we didn't find anything with this mic. No, I'll just stay here. Don't worry about it. Don't worry. So what do we find? Well, we did see an association between stressful life events and sexual risk behaviors, but we also found that the associations were strongest for those who report being incarcerated versus those who do not. Totally in line with intersectionality theory. Again, I've been thinking a lot about this kind of multi-level intersection analysis. So I encourage you to completely do this intersectional analysis, focus on the individual level, but also start to think about geography and how, and other multi-level factors and how that may frame or interpret intersectional analysis. So there's this paper that just came out by a colleague of mine at Yale, Skylar Jackson. And what he wanted to do was he wanted to look at whether policies, structural stigma-related policies influence the mental health. I think the paper looked at depression among Black and Latinx sexual and gender minority adolescents. Not surprisingly, he found strong associations. He found associations with race, ethnicity policies, sexual orientation policies, and policies that looked at both, meaning that policies that were oppressive to both, there was increased effects among the sample, which is consistent with other work. So this is a colleague of mine from Rutgers, Devin English, and a mentee of mine. He wrote this paper looking at intersecting structural oppression and the health of Black sexual minority men. He did a similar analysis with a different data set, again, only focusing on this one population, looking at structural racism and oppression based on sexual orientation, finding both in predicted various aspects of health, including perceived burdensome and heavy drinking, but he also found that these factors together predicted worse outcomes for this population. So I'm going to talk about some of the work that we've been doing with police violence and how this has informed it. So this is a picture of what I perceive to be a white police officer and a picture of what I perceive to be a young minority child, perhaps. So the police officer says, "What do you want to be when you grow up?" The child says, "Alive." And this may seem a little funny or interesting, but this is real. It's based on some data. So it's known that Black boys and men, as well as other Black women and Black girls, tend to feel unsafe in white neighborhoods. And the reason why they do is because we actually have quantified as scientists that death by the police is a leading cause of death of Black men, unfortunately. Some media clippings of that. And this is a quote from Jacob Blake's sister. Jacob Blake was one of many Black men who have been harmed by the police. And his sister said the following: "I'm not sad, I'm not sorry, I'm angry. And I'm tired. I haven't cried one time. I stopped crying years ago. I'm numb." My mom tells me this actually, she's numb. I've been watching police kill people who look like me for years. And I asked one of my RAs, I said, "Can you just start documenting the names for me? Because I want to start to create the story." But there were so many names and so many pictures, I couldn't do them justice. So I was going to acknowledge that. But these are some of the names of, we want to center Black men who have been harmed by the police. You know, we've often talked about George Floyd, perhaps because of the time period we were in during the pandemic, and maybe perhaps people were paying attention to social issues, I'm not sure. But just briefly, he died in end of May 2020 in Minneapolis. And the interesting note is that there were initially conflicting autopsy reports. And essentially the autopsy report initially didn't argue that he was actually murdered. It said that, well, maybe there's some other thing that's happening here. And this contributed to a wide range of protests. As someone who travels a frequent bit, it was interesting to hear when I was in Kenya, and I'll circle back at the end, about how there were protests literally globally. I heard that, but actually hearing it from my colleagues abroad, it was quite fascinating. So there were a wide range of protests, and there have been many more deaths since. So I don't update this slide. I mean, it's a little traumatizing, but I don't update this slide every time. So, but there have been other deaths, David McKee, Rashad Brooks, and these are just Black men. There are many Black trans women, Black women, Black cisgender women, et cetera. And so I think this is interesting because in this picture, this colleague says, or this protester says, I had to change the sign for Rashad Brooks. So we've been doing some work looking at how neighborhood police harassment experiences relate to health among Black sexual men in different data sets. This is a project that I've been working with a colleague of mine from NYU, Maria Khan. And we wanted to first look at whether police violence and harassment related to violence outcomes among Black sexual men. And of course, one thing we wanted to do is we wanted to make sure that we control for past violent experiences. We use data from the HPTN 061 data set, conducting bivariate and multivariable analysis. And just briefly, we see associations, not surprisingly, but what I really want to highlight is that when you look at police harassment due to race, ethnicity, or sexual orientation, we see associations, but we tend to see the associations being strongest, when you think about this combined intersectional measure, meaning police harassment due to race and sexual orientation. We did the same analysis, or not the same, but a similar approach looking at police harassment and a wide range of psychosocial mental health outcomes. And I think this paper is now published. I think it's in Social Science and Medicine. Again, we used data from HPTN 061, where we looked at psychological distress, including distress experienced due to racism and homophobia, as well as depression. And similarly here, we see that when we look at this combined police harassment measure, we see more associations, or the associations tend to be stronger, indicating that yes, these specific aspects of police harassment matter, but this intersectional measure, there's something that's there. Oh yeah. So this is a paper that's currently in review, but we see the same association with substance use and the same association. I think this paper just got accepted, so pardon that I didn't update it, but looking at police harassment and healthcare utilization. So we find that police harassment is associated with medical distrust, and it's associated with missed healthcare visits, but especially when there's this intersectional police harassment. So this is a paper that one of my fellows just recently submitted for a publication, where we wanted to look at whether neighborhood policing practices was associated with HIV status in our cohort. So of course, we coded our data, we cleaned it, et cetera. In our sample for N2, it's a study of over 600 Black sexual men in Chicago, in 3 cities in the Deep South. The numbers are listed there. One of the first things to note is that among those in our sample, among those reporting neighborhood police problems, over 1/3 report either police neglect or excessive police force being a big problem. More substantively, we found that neighborhood police neglect was associated with lower prevalence of HIV testing and lower odds of ART use. And neighborhood excessive police force was associated with a lower odds of PrEP use among current PrEP users, a lower odds of ART use among men who are living with HIV, and a lower odds of HIV status neutral care. But I want to add something. What about the intersection of body size? This is a paper that I present in one of my lectures on race ethnicity, where it's been quantified by our colleagues that if you are a Black and Hispanic man who is larger, actually objectively larger, meaning your BMI is larger, you are more likely to be frisked and searched, and you're more likely to have forced use among you. So in N2, we just did a relaunch to our cohort, which is exciting. We're at our second phase of the cohort. We did the relaunch last year. We're focusing mainly on substance use and mainly on sleep. But one thing we're also doing is in the police violence literature, there's very few work that's looked at non-self-report data. So all the data we just presented self-report. So now I have a couple of colleagues of mine in this project, we're using EMA to look at police encounters, but we have some pending things I'm thinking about where we have objective police data to quantify this. And these are just some pictures from our relaunch. But also, one thing I'm interested in is also looking at these interactions in complicated ways. So in AIM-3 here, I'm actually interested in looking at body size or BMI as an additional intersectional position that may experience people's or influence people's lives. So some of the challenges I think are we need to collect different and sometimes complex data types at multiple levels. And then we really need to think about sizable and thoughtful samples, especially when we want to draw inferences to them. Some future research I see is more research implementing multi-level intersectional perspectives, and then specific health-related interventions focusing on incorporating multi-level intersectional perspectives to the population. So now I'm going to talk about positionality. I've been reading up on positionality for a while. This is one article that I particularly like, and I've drawn on Andrew a lot for my thinking in this space. But these are some of the definitions that people have conjured about positionality. I'll read the middle one, which is one that I prefer. Positionality is disclosure of how a researcher's race, gender, class, and other self-identifications, experiences, and privileges influence the research methods and research, the research and research methods. Here's a little bit more, but it again talks about the who we are and our reflexivity and how that relates to what we do. I just want to say that this, again, is something that's been talked about quite frequently. Bell Hooks, for example, talked about the importance of lived experience. And I want to provide this initial connection between intersectionality and positionality. This is a book on Black feminist thought, which is really a positional piece, I believe, or I'll frame it as that Patricia Hill Collins wrote. And if you remember earlier, I said Patricia Hill Collins, as you may know, is one of the leading scholars of intersectional analysis. So in my mind, they go hand in hand. Due to time, I won't go into the history, but similar to intersectionality, there's this long history of positionality, really beginning in the mid-1920s. And I think about positionality being important for 4 reasons. One, it acknowledges subjectivity, which is debatable, meaning that I'm working on a piece right now where some colleagues argue that having positionality or saying your position actually is somehow identity politics. And so it actually muddies our science, which we can talk about. I disagree with that clearly. 2, it challenges power dynamics. And then 3, it really promotes reflexivity. And I can't think of, I'm not a psychologist, but I can't think of how reflexivity would be a bad thing at all. I think it's really critical to our work. And I've summarized some of the connections that I see between intersectionality and positionality. 1, both intersectionality and positionality prioritize examination and understanding of individual social identities and how they impact their experiences within social structures, and both also elucidate the intricate relationship between individual social identities and their lived experiences. So I view positionality as really a framework for health equity research, and this is partially why I'm moving in this space. It allows us to identify disparities, challenges bias and stereotypes. It really allows us to have cultural humility, and it allows us to advocate for policy change. So from my perspective, the current state of the field really is to, it's a couple slides down, but it's to really do nothing. Just kind of maybe acknowledge it a little bit. The next state of the field is maybe to develop a positionality statement. And I'll share the slides, but these are some of the key questions that I've been thinking about when you develop positionality statements. What should you be thinking about? Who am I in relation to the research? How does who I am affect the approach to this topic? And what manner is this research being conducted? I personally view positionality statements as an aspect of scientific rigor and reproducibility, and I want to start advocating for that, including at national levels. I want to provide some examples of things that I've done. So in my papers, I've talked about my position. I've written a little bit about it, for example, essay in the Medium once. And in my grants, I talk about it. So this is an example from a grant that a colleague of mine have about to be in review. My work in population of interest focuses on Black sexual minority men, given that the strong scientific premise that we cannot end the HIV epidemic without focusing on inequities for this population, and my own position as a Black, cisgender, gay male epidemiologist with Caribbean heritage. But I want to shift the perspective because we don't always represent our populations. So I'm going to talk about another one of our studies called TURNT, which stands for Trying to Understand Relationships Between Networks and Neighborhoods Among Transgender Women of Color. Sorry, I was a little slow at the beginning, so I have to push through this a little further. Oh, no, take the slide. No, it was more so that I can't go through the slides in detail that I want to. But just to say that our sample is all transgender women of color, and our sample is very socioeconomically disadvantaged. For example, you see here that almost 60% report living with food insecurity, and a large portion of our sample make less than $30,000 per year. And this is in the context of New York City. I don't know the exact number, I can't remember that come from the city proper, but most people come from New York City. So one thing that I've been thinking about are what happens when we don't actually represent our participants, including me in this case? What are some of the benefits of centering the lived experience of trans participants? So I've been thinking about my position as a cisgender researcher as follows. Research ideas don't necessarily originate from my own personal experience. And in fact, this idea of TURNT actually came from a friend of mine. We went to college together and she talked about her experience in life and I talked about my experience in life. And I realized, whoa, we have very differences. And we started to talk about the importance of research and ideas, and there came the birth of TURNT. So it was really her idea. Research questions may address the immediate needs of the community and other reasons that I've listed there. I'll skip this, but I'll say that because of a non-shared identity, meaning myself with this study, I've really given a lot of, or been thinking a lot about concrete steps that I can take for myself and my staff to come to a level playing field in terms of positionality. So one, we're intentionally centering trans leadership, meaning a colleague of mine is now an MPI on the study, and all work moving forward. All decisions are jointly made, and that's intentional, and uplifting trans voices in a number of ways. One, we really center the community advisory board on everything. So improving, I just got an email a couple of weeks ago from a colleague said, hey, Dustin, I want to write an R1, and this is what we're going to do. And of course I can say, great. But I said, thank you so much. This is our protocol. And our protocol is my colleague has to be included and our community advisory board has to improve this. Also, one thing that we have been working on is various trainings around sensitivity and et cetera, including from the Transgender Training Institute. This is an example of how I've highlighted my position, the positionality more broadly in a project that we have in review. But there are challenges. I think it's challenging to confront our own biases in a real way and to communicate our practices and positions. But I think there needs to be more. I think there could be further research implementing positionality, including when it comes to sexual and gender minority health research. And I've really been thinking about the power dynamics between SABs and CABs and just the effectivity of that overall. And I really think that we shouldn't have disaggregated CABs and SABs anymore. Power dynamics, conflation of expertise, et cetera. So in all of our work right now, we are thinking about that balance of privilege and power by having an integrated CAB and SAB. So the way forward, as I view it, is a model that I just developed called the Health Equity Research Production Model. It's in review, it's not published yet, but I've been talking about it, which thinks about health equity in the actual production of our science. The papers that we write, the teams that we have, the grants that we write, who's involved in those grants, including any meaningful community engagement. I'll provide one example of an early project. So this is my first NIH award, it was an R21. And part of this model explicitly recognizes not only disparities when it comes to, or inequities when it comes to things about our personal identities, but also in terms of career stage. I think I've been quite blessed and fortunate, is probably a better word, to work with amazing scientists who've kind of helped me hone my ideas and taught me kind of tricks and tips but I don't think that's always the case. And so one thing this model explicitly does is it recognizes that people are at different stages in their career, and there has to be an explicit pipeline for that transition. So this is a former doctoral student of mine who's now an assistant professor at NYU. And essentially, he is now taking over the role of being senior author on these papers. So these are some papers, some early papers where I'm first and he's included, and I'm senior, but on, I think it's 50%, there's a rule, I can't remember the rule, but I think it's on half of the papers, he'll be senior author moving forward. Inequalities also exist in the reproduction of research. We know that non-white scientists appear on fewer editorial boards, they spend more time in their papers under review, and they tend to have fewer citations, which is also why I explicitly highlighted some of the minority scientists in this work. We know that gender disparities, a personal friend of mine, Erica Warner from Harvard Medical School, did this, I think, really great paper looking at gender differences in the receipt of NIH grants. And not surprisingly, there are strong gender differences. So I'm a little out of time. Sorry, I spent a little bit over the first, so I'll just go through a little longer if that's okay. So I'm going to end with Tiawane, which is a project that I'm working to get funded in Nairobi, Kenya. Tiawane is Swahili for nothing for us without us. I went to Nairobi in March of 2023, and I just kept hearing this term, nothing for us without us, nothing for us without us, quite literally. And they kind of gave me the study name in a way, which was kind of beautiful. And then, of course, they helped me understand what it meant in Swahili. A little bit of context, though. I went to Nairobi. During a couple days before I went, this came out, where there's an article about gayism and how gayism is bad. You can imagine as a gay identified man how uncomfortable, maybe, I'm not sure a good word, but how I had to navigate being in that society just for a limited period of time. So while I was there, I met with various community groups, and this is one group of sexual minority men and transgender women, and this is a group of another group of sex workers who were also sexual minority men and transgender women. And these are just some of the key themes that we found. Stigma and discrimination are not surprisingly high in that society, and they're largely influenced by religion and politics. And not all safe spaces were safe spaces. So I did a number of kind of cultural outings, and I heard just many things. I don't want to repeat now, just a little much, but things about just people being dehumanized in many ways, including in spaces that are supposed to be safe spaces for people. In this work, we're relying on the theories, including intersectionality theory. The nuance of the study may not matter as much, but I want to say this. We have an intentional perspective of intersectionality, meaning who we are bringing to the table, as well as positionality. I'm asking everyone to write positionality statements and talk about who we are and how that influences our work. We are centering this integrated CAB and SAB approach. I think that's super critical. We're centering the lived experiences of Black sexual minority men, for example, as research staff. And we're centering the health equity research production model. Just in closing, that both positionality and intersectionality matter. I think that includes scientists from minority backgrounds in research teams, citing scientists from minoritized backgrounds in research products, including grants and papers. And there are many groups who are doing this. My group is one, and we're doing it. Columbia has a new Center for Sexual and Gender Minority Health, and I've been talking to their leadership about the work they're doing, and others as well. For example, John Buchankis, they're from Yale, is doing some of that work as well. And Brian Muskansky from Northwestern has this center, or it's an institute, the Institute for Sexual and Gender Minority Health and Wellbeing, something like that, who's also thinking about these issues. So I look to those groups as exemplars. Thank you. Thank my team. No, my coffee's cold. Sorry for going a little over at the beginning. My bad.
Anybody have any questions?
Questions for Dr. Duncan and And of course, I'm sure there's questions online too. We're not gonna be able to get to every them. And then Vicky, you wanted to mention for early career folks, there is for early career folks, if you're in person, you can come and there's gonna be a meeting just to have a more, I guess,
An informal training session right after this.
yeah, just to ask him questions and kind of, a little bit more about the backstory, although it's cool to hear, like, even in the presentation on the backstory.
Okay. I'll read one question, if that's okay. Is that okay? Just the one question online. Thank you. It's really interesting and important presentation. I appreciate thinking about positionality of the researcher. How do you see positionality coming into focus among study participants and coming to matter in shaping study findings? So it's a really good question because I had a meeting this morning with my RA. I'm writing this new piece on a framework for actually doing this. I think in science, we talk about things very theoretical, and I think that's super important. But the way I think it's very hard for me to think about action-oriented steps. So I'm writing a piece about how we could actually have a framework for actually doing this. So for example, how long should a positionality statement be? There's no consensus. I mean, we're currently doing a lit review to see, but what I know, there's no consensus. And so I have a framework, and I'm not going to say much about it yet because I want to develop it, and but I'm developing a framework for that because I think it's really critical. And unfortunately, I don't think there's any guidance beyond that we should think about these things.
Thank you, Dustin. I want to introduce myself because I am Lindsay Young from Johnson and Respond.
Oh, yes. I didn't forget. I've seen you a lot.
Yeah. I've met many of your several interviews. Anyway, I wanted to say that, and that kind of practices obviously my deep interest in your work. And I just want to thank you for this talk because in my own training with John, I think a lot of this stuff was implicitly or explicitly kind of instilled in us, particularly with respect to positionality. And so one of the comments I had, it's like, it seems like positionality statements are kind of biased towards those who might have either intersectional identities or minoritized identities to make those positionality statements. And I think really it should be people like me who are making these positionality statements, particularly whose work focuses on a community that we don't belong to. And so I've been doing this in presentations for years, following kind of Donna's footsteps, but I've actually started to kind of find places to work this into the people. And I think that's really important, should be part of the conversation. So thank you. And the other comment, and I'd be curious to see what this, but you talked about the civil rights work and intersectional research and what it should look like and kind of different, kind of had quantitative approaches to doing it. Mixed methods, thoughts on that. And I know it's a struggle sometimes with NIH and kind of just the expectations of health research, but something that I've been thinking a lot about as like a quantitatively trained network scientist who's trying to incorporate more mixed methods so that they can get to some of the experience.
Yeah. So the hard part about this paper for me that I'm developing is that I'm mainly centering Black sexual men because that's where a large part of our work focuses on. But I'm very thankful that we have another study that there are aspects of relation, for example, being part of the broader SGM community and centering racialized minority experiences. But I think that you're completely right. And so one thing that I've been struggling with is that, yes, it's easy for me to develop these statements because perhaps I represent aspects of some of these groups, but I'm trying to argue and I'm trying to figure out a way to say it thoughtfully because it does put the burden from my perspective, and others have argued, on the minority scientists.
If you need help figuring out a kind way to say it to white people like me who represent or cisgender, heterosexual, presenting folks, like we need to lean into this. And it shouldn't, and the thing that I'm struggling with is figuring out, because there's word length constraints in papers where you can put this in and do it in a meaningful way. And I would love to kind of, and I'm eager to see this paper come out because I want to think through how to do more than just a boilerplate couple sentences of like, this is my positionality, and of course, my interpretation of findings are probably going to be influenced, but to have more of a dialogue about like, really how my interpretation of some of this stuff is very much conditioned by my input.
So that's what the paper is all about. Because, well, because I think like it's easy, like for us to have a knowledge thing, for us to have a knowledge thing that says, hey, Lindsay, this is what we should think about. But like in practice, what does that mean? Like, does that mean that in the method section under variable X, you say, we got this because of RA? So, you know, like, how does that work into practice? And I'm still kind of working out some of my thoughts. It's a little bit, I feel like it's like even the model, like when you think about Nancy Krieger's ecosocial theory, her first paper, it was really more of an essay. It's kind of like a framework, and then over time she started to develop it. And I by no means want to be the only person to develop this, or think through it, but I want to start having us come to something concrete. Because if we don't, that little example that I talked about Orlando with, you know, fried bait, which is a silly example, and it's a true example. I asked my cousin, what is this? I didn't know what it was, because it looked a little bit different, but it looked like what I thought it was. And said, oh, she knew instantly because she knows me and my background. But I think that we have to. I think we have to start moving into that. And what I'm also trying to balance in my mind is something that's also pragmatic in the current system that we have, because word length is just such a critical part of everything, especially with the more scientific high impact journals. You want less words. So I don't know what that means, and I'm trying to think through that part, but like I want to submit it on Friday. So we'll see, but I'll send it to you, Lindsay. Yes.
I'll talk loudly. Can everyone hear me?
Yes.
Well, on my.
Here.
But go.
So, big fan. Excellent talk.
How do you do
I want to encourage you to also use more concrete examples of the Johnny case. And so in my career, I've observed in the HIV space, the development of literally hundreds of individual-based or small group-based, multi-sector, and complicated psychological interventions to get people to conduct or antidepressants or into treatment. And the CDC ultimately abandoned all of these efforts because they weren't practiced, given the amount of money that's available for prevention services, which, by the way, is about a third of what we spend on HIV. So, I do think it's, what you've identified is futility, scientific futility. And I don't think people are calling it out enough, that the agenda that CIA has adopted, particularly in HIV space, but it applies to, at least dozens of others that I won't get into, mean that they're creating the science that goes. And so I think that that's really important, because it then makes the point for why what you're arguing for in terms of positionality and engaging the communities is actually more scientifically rigorous, right? It's more likely to be both valid, reliable, and lead us to things that will actually. I totally agree with you.
I'm not getting. I get excited. I totally agree, Ricky. And in the paper, what I think that we feel, or I'll say it this way, I get the sense that colleagues feel that cultural rigor or cultural resonance and scientific rigor are almost competing, or that scientific rigor is something that's different. And yesterday I spent part of my day trying to articulate to myself, and in this piece, like they're actually one and the same. And I'm starting off with kind of health equity research, given my dean's role, but also because I think that's where it makes the most obvious sense. But I think it's for all research, quite frankly. That little example, I was literally at a wedding and I didn't know what it was. So if I were to answer that, given my own background, I would get it wrong. That's a big deal. I agree, Ricky. Yeah, I appreciate your thought. And I think that the reason why I think we need to do it is because I've been so frustrated, and I'm thinking about John now, from doing all of this observational work. It's great, and I'm proud of my team and proud of myself for the work we're doing. Our trans cohort, our core of transgender women of color, we have 83% retention rate. That's amazing. My staff are great. However, what next? What next? And I really believe that all the data that we get, of course, influence the interventions. And the interventions aren't so good, to my knowledge, as a non-intervention person. We still see these disparities. We still see these things existing. I mean, I think I wrote my first kind of paper about health disparities as a college student, like a senior. And my mom was a professor, she's retired. And she said, she said something like, I've been doing this for years. Nothing has changed, literally. And with complete frustration and not acknowledging that I got my first little paper, right? You know, and it wasn't about me. It was about that she was frustrated because these are also things that she experiences as a Black woman in America and a Caribbean Black, you know, et cetera, et cetera. But I think the conversation needs to happen because if we don't make a change, then, you know, when I retire, and I don't want to retire when I'm, you know, I want to retire sooner. You know, when I retire, these things aren't going to change, quite literally. And I think we have to do better science, and I think that we can. Thank you with that.